I'm pleased to introduce Dr. Elaine Petrof. Dr. Petrof received an award from the PSI for full funding, 2-year funding in 2010. She's a well-established investigator and has published in a number of prestigious journals, including gastroenterology, critical care medicine, and microbiome. And it's actually a good segue because as Bill had sent us on a biologic break, we're going to hear about Dr. Petrof's work around the microbiome, which is a really fascinating and expanding area of work. Dr. Petrof's research interests focus on the role of good bugs in the gut and how they influence and are influenced during inflammation and stress, and also for the treatment, for the management of inflammatory intestinal diseases. So to welcome Dr. Petrof.
Well, thank you for inviting me. I'm delighted to be here. And I wouldn't be here if it weren't for all of you. So first of all, I just want to thank you, and I really mean this, because this work we submitted our proposal to CIHR initially, and they considered this high risk, and they said, you don't have enough publications to show that you can actually do this work, and you guys, you folks funded this. And just to give you an idea of metrics of what we were able to accomplish with this study, this received a lot of media attention. You may have heard about it because it was on CTV News, it was on All in a Day, it was on Radio-Canada. I did an interview in French for them. It was showcased in Maclean's magazine, it was in National Geographic, it was on NPR. And not only media attention, but also in the scientific community. It was also showcased in Nature and Science magazine. It was in the Nature News and Science Focus. So this would not have been possible without funding from PSI. So I just wanted to say that right up front. So just to get an idea of the scope of the problem. So this is US data. Unfortunately, we don't have the same kind of data for Canada, but it's very similar south of the border as what we see here. This is just to give you an idea of the scope of the problem with C. difficile, and particularly our focus in this study was on recurrent C. difficile. So if you have 500,000 cases of C. diff, you can get a sense if there's a roughly 20% recurrence rate of C. diff infections that don't respond to antibiotics and they come back over and over again, that you're looking at fairly large numbers with a fairly significant burden on the healthcare system. And then this is just data from Quebec. You probably all remember this study that came out a few years ago in New England Journal. And really, the incidence of C. diff was much higher in the elderly population. And that's what we were seeing also at our hospital at KGH. So recurrent C. diff is definitely something that we're seeing more and more of in the hospital. And what ends up happening is these patients end up like these revolving door sort of situations where they go out, they relapse, they come back in, they get treated with vancomycin, they're okay for a while, then they go back out, they relapse, and so they keep coming in and out of the hospital, and we can't actually keep them out because they're not actually cured of the disease. And so in patients that end up in that sort of scenario, we know that vancomycin only works about 30% of the time, which means that you have a 70% failure rate. And this is not a problem that's unique to us in Canada. This is a problem that they're seeing globally. And one of the treatments which seems to actually work, as bizarre as it may sound, is a fecal transplant or stool transplant. So the idea behind this is that you're repopulating the gut, hence the name of this study, repopulate. You're repopulating the gut with natural bacteria that normally should be present there, which outcompete and suppress the C. diff infection, and the spores are not able to germinate and cause disease. And so this has been actually around for a long time. The first study that used this for pseudomembranous colitis came out in 1958. And there are reports of fecal transplant therapy being used as far back as 2,000 years ago in China. But this has just sort of been resurrected more recently because of the failure rates that we're seeing with vancomycin. And so this was the first RCT which had been reported. And I won't go through all the details, but just to summarize the data, the bottom line is that the fecal transplant actually had a fairly remarkable cure rate based on assessment at 10 weeks. And so you can see with the first infusion it was about 80%, and 3 of those patients required a second infusion, in which case the success rate went up to over 90%. And as we have all seen, vancomycin success rate was around 30%. So we've actually been doing fecal transplants at Kingston General Hospital since about 2009, but they're not without their issues. So we started to actually study this a little bit, and I'll show you an example of this on the next slide, but there is actually some fairly significant variation in the donor composition of bacteria over time. So in terms of regulating this, this is a bit of a challenge. There's always a risk of transmission of viruses and bacteria. So even though we screen the donors, and the way this works is the donors come in and we screen them sort of like you would do for blood bank screening, and we additionally screen for parasites and other intestinal pathogens as well. But there's a 2-week window from the point where you do the screening test and get the results back and when the procedure is actually initiated, where you infuse the stool back into the patient, where you could theoretically have transmission of something if the donor had caught something during those 2 weeks. The long-term complications of this are unclear, and this is difficult to study because a lot of the donors are different and the hosts are different, because a lot of people will bring in their family members to donate, so it's not like you have one donor across the board where you can just sort of follow consistently what happens. Every center has a different donor. So the signal to noise ratio of picking out a long-term complication is going to be challenging at best. And then sample stability, this is being studied now where they're doing frozen versus fresh and things like this. Particularly in the US, they're looking at frozen compositions of stool. And then finally the ick factor, which is kind of self-explanatory. And this is just to show you what I was talking about, variation in donor over time. This was a case that we did several years ago. It was a woman with IBD who had recurrent C. diff, and we transplanted her, and she did very well with a fecal transplant. This was the analysis of the composition of her stool. So this is based on all, this is just, sorry, this is really small, but basically just think of it as each color is a different family of bacteria. So we were just kind of looking at what was in there. And then over a year later, she relapsed because she got admitted to the hospital with pneumonia, got moxifloxacin, and then ended up with recurrent C. diff again. So we went back to the same donor, her son, and asked if we could do another transplant. So we did it identically as the one that we did initially, and we found actually that the composition of his stool was completely different. So having said that, they both worked, so does it really matter? Maybe not, but in terms of what Health Canada wants everything to be very tightly regulated, clearly using the same donor, which is what they had initially suggested for the clinical trial, doesn't really mean that you got the same stuff over time. So then we, this was actually a meeting that was put together. We kind of pulled everybody from across the country that was interested in this area of fecal transplant. We called ourselves the Ecosystem Therapeutics Working Group. And basically you can see we had a fairly multidisciplinary group looking at fecal transplant and some of the issues surrounding this, because really this was a little bit like the Wild Wild West. Everybody was kind of doing their own method and, administering from above, administering from below. Some were using the same donor, some were using single donors, some were using gigantic volumes, others were using very small volumes. So we tried to sort of figure out who was doing what and what worked and what didn't. And out of this meeting, among other things, and the Health Canada regulatory people came to this meeting as well. So it was actually very useful for discussing this last point 8, how should it be regulated. But what we became interested in is this point number 7, are there better ways of accomplishing this, such as the use of a synthetic stool transplant. We call it synthetic. You'll see what I mean by that in a moment. And then related to that, number 5, what are the optimal combinations of strains that we could use to treat recurrent C. diff infection? So that's what I'm going to talk to you about. And this was a paper that was published describing this work. So this is really proof of principle. It's only 2 patients that are reported in here, but I'll just briefly run through how we came to this. This is what it looks like for anybody who's interested. A little more palatable than stool. So our approach was to start off with the donor sample, and basically this is a cleaned up stool transplant. That's how I tried to describe it to Health Canada. We take our donor and I take our sample, and we're removing everything that we consider may be harmful, culturing it in a controlled environment, and then infusing it back into the patient. So similar concept as a stool transplant. So, and just, I want to put in a plug here for something that I think is going to be an emerging paradigm in medicine, especially with everything that's emerging on microbiome therapy. So basically, you've probably heard on the news that fecal transplantation is being used for a lot of other indications. The jury is out as to whether it actually will work for these, but it's been proposed for obesity. I mean, they've done animal models and have shown that actually if you do these fecal transplants from fat, genetically obese mice into skinny mice, the skinny mice gain more weight. So people are interested in using it for that. It's been used in ulcerative colitis. There's a trial actually at McMaster going on right now looking at ulcerative colitis and fecal transplantation. So there's a lot of other disease systems that may potentially be amenable to this kind of therapy. And so what is a healthy ecosystem? The way I define this is a full functional repertoire of genes, because we know that our microbiome actually serves some useful purposes for us, ranging from helping with the immune system to metabolizing nutrients to making vitamins, that it can exist in a stable equilibrium as a community, so we're talking about an ecosystem, and that it colonizes and persists. And that is in contrast to probiotics. So probiotics are basically bacteria that were developed and made for fermentation in the dairy industry, but if you take them and you stop taking them, they just pass on through. They don't stick around. So that is because they're not adapted for the gut, whereas we're starting with something from stool that's used to living in that environment, and so it will adapt more easily to colonize and persist. So in order to do this, we use this thing that it's a modified chemostat, and we call it a RoboGut. So basically what this is it's an artificial colon, if you like. It's a modified chemostat that's been set up to sort of mimic the conditions of the distal human gut. So this is, and I'll show you a photo of it in a minute. So basically it's a continuous culture system, so just like we eat and we defecate, the chemostat does the same thing. So media comes in, this has all the nutrients in it, and then the spent media is sent back out again. There's a stir in here, which is meant to sort of mimic peristalsis. There's a temperature probe, and this is all maintained by a computer system, which keeps the temperature and the pH constant. And then there's a HEPA filter here, and anaerobic gas is bubbled in to keep it all anaerobic. And it's all run by a computer. So this is what it looks like. These things are modular, so Here's the computer on this one. You can hook these up to each other. Here's the vessel here. You can see it's full of poop. This one has been removed. So here there's 2 vessels on each machine, and the media runs in through these tubes, and then you can't see it, but it runs out through the back. So that's the system that we're using. And then you put the sample in there and you let it run over several weeks, and then you get a stability indices, which you can determine the ecosystem robustness of what you have. So this is all sort of basic principles of microbial ecology. I'm not going to go into this in a lot of detail. So our donor that we chose, and actually a colleague of mine was joking about how you have to basically be a Greek god to be a donor. We picked a very supremely healthy person, and it took us a long time to find this person, actually. So she was in her early 40s, and so they do the same thing when they screen for fecal transplants. We pick very healthy people, but we had a few additional criteria that we really felt strongly about. So one was normal vaginal birth delivery. So we know that C-section actually messes up your microbiota, and they're drastically different if you look at babies who've been vaginally delivered versus C-section. So we wanted someone who'd had normal vaginal delivery at birth. Breastfeeding, another big one. We know that people who get fed formula versus breast milk have dramatically different microbiota. So we wanted someone who had been breastfed as an infant, no antibiotic use as a child. We now know that this is really turning out to have a lot of nasty associations. There's a recent study that came out in the UK last year showing that antibiotic use as a child is actually there seems to be a direct association with the development of Crohn's disease over time. So we didn't want any antibiotic use as a child, and she had had one remote antibiotic use in adulthood. And then finally, very healthy, would seek out organic produce, very fit, didn't drink, didn't smoke. I mean, really your perfect donor. So surprisingly, this perfect donor still had some bacteria in there that we had to take out. So we take her sample, we put it in the robogut, we grow it up, we isolate all these bacteria out. So we got out about 70 different strains. And so out of those 70, we then sent off for sequencing, we cultured them, we identified what they are, and then I took out about half of them. So we were left with 33. And these are just some examples of some of the ones that we took out. I didn't put some of the others up there. So she had Pseudomonas in her stool. We don't screen for that when we do fecal transplant, but we took that out. She also had Staph aureus in there. Don't know why that was in there, but anyways, we took that out as well. And so we took out pathogens, or things that we know could be potential pathogens. We took out other bacteria that, so this is a good example. This may not actually be a bad bacteria to have. However, we did test for antibiotic resistance, and if any of the strains were resistant, we took those out too. So this one particular, when we plated it out and we dropped Kirby-Bauer discs, it would grow right up to the edge of the disc. So if, God forbid, something should go wrong and this thing gets into the bloodstream and we can't get rid of it, that was our concern. So we eliminated all of the ones that had antibiotic resistance that were concerning to us. And then there were others that we weren't really sure. So E. coli. E. coli Nissl is a probiotic. It's considered good. They use it to treat ulcerative colitis. E. coli 0157, bad, can cause renal failure. So we chose the more susceptible strain because there were more than one strain of E. coli in there, and we picked the one that, we checked for toxin genes and stuff like that. So we took the more benign E. coli strain. And so what we were left with was the list that's here. So we picked 33 strains. We identified them, as I said, by sequencing. We preserved them at -80. We cultured them, and then we took them back and put them back together, put them back in the robogut to make sure that they still held together as a community and was still a robust community. And it turned out that that was the case. So then we went back and we, using this MetaRep database to sort of figure out the relative amounts, by biomass. We put together our mixture, and that should actually be times 10 to the 9th CFUs per mil. And so we ended up with 100 mils we put it in degassed 0.9 normal saline and infused it. The patient's vancomycin was held for 48 hours prior to treatment, and then we infused it through colonoscopy. So we basically went up to the ileocecal valve and drizzled it as we pulled back the scope, and then flipped them with their feet up for about an hour, and then they were on their way. So I'll just show you what happened with these two patients. So this first patient, her initial inciting trigger, if you like, was cefazolin for elective knee surgery. And after that, she developed recurrent C. diff, and this is just highlighting all the time she got metronidazole, vancomycin. These are the C. diff tests, positive, and had diarrhea all of this time. So you can see this was going on for over a year by the time she was referred to us. And then this is just showing her pretreatment, and when we gave her our mixture, which we called Repupulate, and then day 2, week 4, and subsequent testing for C. diff was negative and her diarrhea resolved. Patient number 2 had basically recurrent soft tissue infections was sort of her inciting problem. She had a neurologic, like a neuropathy, not diabetic neuropathy, but she was being followed for neurology for this. She got cefazolin and then developed recurrent C. diff. And the reason she ended up coming to us was because when they tried to decrease her vancomycin and taper it off, she developed diarrhea, and she couldn't actually afford Vanco. You guys probably all know it's super expensive. So they put her on metronidazole, and then her neuropathy started to get worse. So they had to send her to us because of that. And then that's sort of her story. And then one more thing that's a bit different about her. She developed another soft tissue infection sort of between week 2 and week 4, and she ended up needing to be admitted for IV ceftriaxone. So just to sort of show you what happened with the bacteria, so both of those patients responded within about 3 days, and they did not recur. And so just looking at what happened with their microbes in their gut. So these are principal component analysis plots. And basically what this does, to sort of summarize it in one line, is it looks at similarities in samples. So if you look here, pretreatment sample is here, and our Repupulate is here. So after the patient received the Repupulate, the pretreatment sample shifted to have a profile that was a little bit different. And then after a couple of weeks, it settled out somewhere in between the pretreatment and the Repupulate sample. So it's sort of a composite of her original and what we infused in. Over here, this patient is slightly different, so her pretreatment sample was quite different. So the distance on this gives you an idea of variation between the samples. And again, day 2 and week 2 were quite similar now, bearing in mind that she got antibiotics between week 2 and week 4. So that may explain why this sudden dramatic drop down to here. But again, somewhere in between the pretreatment and the Repupulate sample. And then, I won't go through this just in the interest of time, but this is looking at, again, these are looking at families classified by color, and you can see the differences between the bacteria. So this is what we put in over here. This is what they look like initially. And then this is just showing over time how they change. And you can see, for example, they both have a lack of Bacteroidetes, that's the red, and that increases over time. This one has a lot of Enterobacteriaceae, so that's like E. coli, a lot of gram-negatives. This one, interestingly, didn't have as much and had fairly decent variation or diversity, but in fact still didn't do as well and still developed recurrent C. diff. So it's not only about diversity. It's also what bacteria that you have. And then this is the other interesting point that I wanted to draw to your attention. So these are the same timelines, but what I'm drawing to your attention here is this. So this, I showed you the data up to week 4. And here, at our 6-month follow-up, we brought them back, did a comprehensive closeout of the study with them. And what we found out is that they actually had been receiving antibiotics from when we saw them in week 4 through to when they came back for the follow-up from their family doc. So this one had a history of recurrent UTIs, had received Cipro, macrobid, and amoxicillin. And this lady with the recurrent soft tissue infections had received some cephalosporins and metronidazole, unbeknownst to us actually as well. But neither of them relapsed. So that was in contrast to a lot of the fecal transplants that we have done who have come back, gotten antibiotics, and relapsed. So this is very intriguing to me. And I think part of the reason might be that we tested this community and it was fairly robust, and so it kind of got a test run before we actually used it. And it was able to, even after multiple hits of antibiotics, was still able to prevent these patients from relapsing and developing C. diff. Okay, so and this is just the 6-month, so basically 20% of the strains were similar in patient 1 and 36%. So basically, your microbiota remodels to be a mixture of what was put in and your original bacteria. So to kind of wrap up, the advantages of this system, I think, are that we know exactly what we're putting in and we can control what we're putting in. So it's known and it can be standardized. If we have to go back, we can do exactly the same thing again. And also, conversely, for looking at long-term outcomes. So this is a concern that's been raised by Health Canada and the FDA. How do we know what the long-term effects of this is going to be? This is sort of a broad general thing that they're worried about for fecal transplant too. The advantage of this system is we know exactly what we've put in. So if, God forbid, there's some study that comes out that shows that one of the strains is associated with a malignancy, we can actually tag who got what. We could take that bacteria out. We can follow that. We actually could do a registry with this sort of situation because we know what we have. So I still think that even though we don't have a crystal ball and we can't predict which bacteria may be good or bad, at least we can follow it and we can intervene if necessary. And because we have the antibiotic susceptibility profiles, we could actually get rid of anything that was considered to be harmful in the future. And then finally, it's fairly stable. As I mentioned, absences of viruses and pathogens can be ensured. And not so much an issue with the patients, but the endoscopy nurses love this stuff. They prefer this way over stool. So in terms of getting the procedure done, you get a lot less pushback. So challenges that we've run into, these are not easy bacteria to grow. They're strict anaerobes. And scaling this up commercially, I don't know how feasible. This was kind of our hope when we were doing this study, is that we can, set this up and distribute it all across Ontario. So this may turn out to be a little more challenging. I think maybe I was a bit naive thinking that that was going to be that simple. I still think it's doable, but it's turning out to be a little trickier than I thought. The thing that also I hadn't realized is how much this actually costs to do. So each run on the RoboGut is about $1,000 just in reagents, and you need very skilled personnel to do it. So the initial stuff was done in Guelph. We now have a RoboGut set up at Kingston General Hospital, and we've got some funds to set up a RoboGut facility, which we're hoping to use to make clinical grade manufacturing of this. But I had to actually hire the PhD student from Guelph who was working on this initially to come and work in my lab to be able to do it, and it's taken her 2 years to train my technician. So it's not an easy skill to learn, whereas stool is cheap. So that's another challenge. And then finally, the regulation of this is turning out to be not easy to navigate, partly because Health Canada doesn't really know how to classify this. So we're meeting with them on May 27th to try to iron all this out again, but this has been going on since the study, so basically we're still bogged down in the regulatory stuff. So basically what they had told us is, we reviewed our data with them, and they said, yeah, it looks great. Now stop what you're doing, put everything on hold, do this, 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 this. And so we're working through that list, and we have to go back and review where we are with them later next month. So, but the good news is this demonstrates feasibility. This can be done. And I think that it's going to be a better way to go than using stool. But I'll be the first to admit that we still need to understand a little bit more about how this works. And I think it's possible to actually play with these mixtures to come up with communities that may serve for other functions going forward for the disease states. And I'll finish up there just to acknowledge the people that worked on this project, and PSI, obviously, for getting this going. CMO picked up, because we ran out of money to finish the study, so they kind of picked up the end, and then CFI has actually given us money to set up the RoboGut facility, and those blueprints are underway. So, thanks.
I'd like to open for some questions, and as Bill has notified me that I should use the mic, if people could come forward to the microphone, that would be much appreciated.
Hi, it's Andrew Baker. I don't know whether I missed it, but it's just a technical thing, but when you culture a person's biome, how do you know that the relative frequency that you see isn't affected by the culture process itself?
Great question. And in fact, you don't. So that was one of the reasons that we would culture it and then put it back into the RoboGut almost as soon as possible, because you're absolutely right. If you passage these, and we've done this actually, if you passage these bacteria on plates, their phenotype starts to change. In even 1 or 2 passages, already you can see a difference. So you're right. You have to sort of not do that. So what we would do is we would culture them on the plate, immediately freeze them, and then reconstitute them right away. We did not passage these bacteria for exactly that reason.
Thank you very much for an interesting talk. What is compared to the old standard of unpasteurized yogurt, the bacteria in that? How does the efficacy of your new method compare with that? So the unpasteurized yogurt tends to have lactobacillus and bifidobacteria in them. And so those particular bacteria have been studied in probiotic studies looking for antibiotic-associated diarrhea. It looks like they do have beneficial effects. For C. diff, it's unclear. Some say that it works, some don't support that it works. And for recurrent C. diff, there is no data. So I don't know for recurrent C. diff. As far as I'm aware, just based on my own experience, because these patients, when they come in to see me in clinic, by the time they hit my door, they're pretty desperate. They've pretty much tried everything, and probiotics do not work in their case.
Given the enormity of the problem and the commonality of the problem, I'm fascinated and surprised that industry hasn't jumped on this. That somewhere in the great beyond there aren't groups that have decided if we can make the perfect artificial stool and market it at $2,000 a squirt, I'm good to go. And the shareholders would be thrilled. So I'm surprised industry isn't on this.
So they have come knocking on our door. Maybe this is a stupid thing that we've done, but actually they all want us to strip down the mixture. They're like, 33 strains is too many, strip it down, strip it down, strip it down. That's what they want us to do. And we actually disagree with that. The whole point of this is to have a community, an ecosystem. So stripping it down will just make it into a glorified probiotic. So in principle, I think that is wrong. and I would not support it. And I'm not going to turn our stuff over to some company that's going to screw everything up, run a trial and say, oh, it doesn't work, but that's because they've messed it up because they've stripped stuff out of it that was important. So you're right, they're interested, but so we're waiting to find the right. I mean, if we find someone whose ideas and conceptually are aligned with us and what we think is the way to do this, then we're all for it. But so far, we're it's just, I don't think it'll work if you strip it out. So, because probiotics are essentially that. There are a few strains. So yeah.
So I'd like to thank Dr. Petrof once again for an excellent presentation.